Good evening. This is my case study. I will be presenting on case study 4. I'm Angela Lafferty, and it is about deep vein thrombosis. So, deep vein thrombosis, this is a 58-year-old male who is noted to be overweight, a smoker. He uses alcohol and presents with left lower leg pain swelling that began 6 days ago as his chief complaint and is now worsening over the last 24 hours. The pain he has rated as an 8 out of 10. He has a history of DVT 4 years ago that was treated with warfarin for 1 year. The patient has had type 2 diabetes for about 5 years and has been treated with glyburide 5 milligrams for the past 3 years. He states that he is the dean of pharmacy and has been for the last 11 years at a school, which is potentially a sedentary job. So he does smoke a pack a day, and he drinks daily, and he does increase his drinking on the weekends. It's probably safe to assume that has more of a sedentary lifestyle due to his increase in swelling and pain in his leg as well. No history of recent travel, surgery, or trauma expressed by the patient. And so given this presentation, it's strongly suggested and suspected that he might have a DVT. So, deep vein thrombosis, or DVT, is the formation of a blood clot in the deep vein, most commonly in the lower extremities, according to Waheed. The diagnosis can pose a serious risk because if the thrombus dislodges and travels, it can result in pulmonary embolism, which can result in death. So DVT will develop from a combination of 3 factors, which is known as Virchow's triad. So that is venous stasis, endothelial injury, and hypocoagulability. So multiple risk factors are present. So this patient is obese. He has a history of DVT. He has chronic disease, which is diabetes mellitus type 2. And these are all risk factors to increase the development of thrombus. So the epidemiology of DVT remains a major health concern as 900,000 to a million people are affected by DVT annually, according to the CDC. So the risk factors increase with age, obesity, chronic illness, such as type 2, and patients with a prior history. Men are also at greater risk than women. So the pathophysiology of the DVT process is really based around the Virchow's triad, which again is venous stasis, endothelial injury, and hypercoagulability. So venous stasis is slow blood flow. It can be either from immobility or obesity. Many things cause immobility, maybe surgeries, a sedentary lifestyle, or injuries. So endothelial injury is a vessel wall damage that activates coagulation. So the hypercoagulability is the increased clotting tendency from chronic illness. So this patient has decreased movement due to his job not being a very active one, decreased mobility, of course, due to the recent increase of pain, and he presents with obesity, chronic illness, which is type 2 diabetes. Therefore, that makes him more susceptible to clot formation. So at the cellular level, the process begins when the endothelial lining of the vein is injured or becomes dysfunctional. So this is a cascade. So the injury exposes collagen and tissue factor, which will immediately activate circulating platelets. These platelets will adhere to the damaged vessel wall. They release a chemical mediator such as adenosine diphosphate and thromboxane A. These interact and activate additional platelets, amplifying the aggregation process. So if you look on the slide, you can see kind of the transition from one to the other. So at the same time, there are some intrinsic and extrinsic coagulation pathways that are triggered, which generate thrombin. Thrombin comes in and converts fibrinogen a soluble plasma protein into fibrin, which is an insoluble protein that weaves into a mesh and stabilizes the forming clot. I always picture it as like a bag of, like a net bag of balls, like sports balls. So the red blood cells and the platelets become trapped in the fibrin network and then produce more of a solid thrombus. So now there's an inflammatory response that plays a major role. So cytokines like interleukin 6 and tumor necrosis factor alpha perpetuates endothelial damage and then further promotes clot growth. So when there are circumstances present like chronic disease, obesity, this balance is disrupted and clots are not able to be naturally dissolved. So the thrombus may enlarge and obstruct venous return or potentially loose and cause, like break loose and cause potentially fatal PE, which is a pulmonary embolism. So this cellular sequence is vital for the advanced practice nurse to identify early warning signs, to initiate timely therapy and educate the patient on decreasing risk factors appropriate or associated with their presentation. Oh. Okay, so now you have the clinical manifestations. So this is a case of a 58-year-old male who is presented. Well, let's say this. You have your pertinent subjective data and then your pertinent objective data. So we need to talk to the patient first. So he is a 58-year-old male patient who has now presented to us with 6 days of swelling and pain in his left calf and ankle, which has gotten worse over the last 24 hours. He has stated to us that his pain is an 8 out of 10 on the pain scale. 4 years ago, he had a history of the DVT, which was treated with warfarin for 1 year. He also has chronic condition of type 2 diabetes with mild hypertension. In his social history, he has a few risk factors as well. These include smoking a pack per day of cigarettes, daily alcohol use with a heavier use on the weekends, obesity, and a sedentary lifestyle. He does have a family history of cardiovascular disease in his father, which has increased his vascular risk profile too. So then we're going to go over to the pertinent objective data. Upon physical examination, I'm just going to list the abnormalities, as there was a lot of things that were fairly normal. But he does have a few abnormalities were noted and pertinent to the diagnosis. So his left calf was visibly swollen to twice its size, warm to the touch, and tender. These are classic signs of DVT. He has bilateral wheezing, possibly reflecting early pulmonary involvement or related to his chronic use of cigarettes, so his smoking. His heart rate is slightly elevated at 110 beats per minute, which could be consistent with his presentation of pain or possibly some systematic inflammation. So his laboratory findings support a hypercoagulable and inflammatory state. So his fasting glucose is elevated, which is demonstrates he's not controlling his diabetes, which increases his risk as well. His WBCs are elevated slightly at 12,200, indicating an inflammatory response, possibly. His homocysteine levels are high, very high, and this shows endothelial injury and a clot formation in process. His cholesterol is markedly elevated at 280, further increasing his vascular risk. And then he tests positive for protein C deficiency, which decreases the natural anticoagulation and predisposes him to recurrent thrombus. Protein S can lead to an increased risk of clots as well. So we did do a Doppler ultrasound, which confirmed that there was lack of blood flow to the left lower extremity, solidifying the diagnosis of DVT. There are findings that are acquired and inherited in metabolic disease, smoking, obesity, and genetic deficiency that all interact to promote the formation of a venous clot. So the role of the advanced practice nurse in the Christian worldview. So our role as the advanced practice nurse has to go beyond diagnosing and treating a disease. The provider must see each patient as an individual and a whole person, body, mind, and spirit. Caring for them with compassion and clinical excellence goes all the way back to the beginning of nursing with like Florence Nightingale. With a Christian worldview, nursing is seen as a science as well as a ministry. So in this patient's case, compassionate care needs not only to be addressing the physical manifestations of DVT, but also recognizing the emotional and spiritual burdens that he may be carrying. This includes providing education about lifestyle changes, offering encouragement for smoking and alcohol cessation, and being present as a source of hope that it can be done. So as a Christian, we need to be reminded that every patient is deserving of dignity, respect, and that is more than just curing a disease. Looking to restore wholeness is fostering peace for each patient, and fostering peace for each patient is vital. This is why I like the scripture in James 5:15. So, and the prayer offered in faith that will make the sick person well, and the Lord will raise them up if they have sinned, and they will be forgiven. So Christ's love will be reflected through every act of care that we offer as a provider, whether in clinical practice, mental health, or through the balance of science and spirit. And that's where true healing occurs. So there are a few diagnostics that were not discussed in this case study. Are there any that you might add as a provider that might better confirm or aid in confirmation of the DVT? So as providers, we have to always be asking ourselves questions to further the investigation of our patients to provide the best treatment. Our worldview is vital and will make choices in the care we are providing, and including the patient and the family and education process is important to change the outcome. The big question I am always asking myself is, how can I affect this patient in a positive way that will enact change in their lifestyle? So how does this patient's lifestyle factor in, like their smoking, alcohol use, and diabetes, interact on the cellular level to contribute to the endothelial injury and promote clot formation? Also, what diagnostic tests best confirm a DVT, and how do their results guide treatment decisions? And then what lifestyle modifications and patient education strategies are most effective for DVT prevention in high-risk individuals like this one? So thank you so much for listening to our case study today on case study 4 on DVT.